Regenerating.
Little grandbaby.
You know what?
All right, are we live on Zoom? Okay, we are live on Zoom. All right. Yep.
Too long. Too long. Too long.
Go ahead and go. We good? All right. Here, just, I'll introduce you to you. You come over here.
The students I met are.
Of the semester. Yeah, yeah. Welcome, everyone, to tonight's Timothy A. Johnson Medical Scholars Seminar. We're so excited to have so many of our colleagues joining us in the room as well as on Zoom. This is the Medical Schools Seminar Series that we host jointly with our colleagues at FBRI and with our TBMH program, Translational Biology, Medicine, and Health. And this seminar series allows us to bring in speakers who really highlight the VTCSOM identities, in particular, our scientist-physician identity, but all of our identities focus on asking really good questions. So we're really excited tonight to have you listen to our speaker, but first I'm going to allow someone who has been mentored by our speaker to introduce him. So Dr. Michelle Rockwell will give our speaker's introduction.
Wow. Thank you, Leslie. I'm so excited that Dr. Fendrick is here. That's the good news. The bad news is he has no voice because we made him fly into Charlotte and I had a list of questions and I asked him 3 hours worth of questions the whole way here. But I'm going to give you an abbreviated bio and introduction for Dr. Fendrick so that you can have lots of time to hear from him. Dr. Mark Fendrick is a professor in the Department of Internal Medicine and the Department of Health Management and Policy at the University of Michigan. He is the director of the University of Michigan Value-Based Insurance Design Center. He did his residency training at University of Pennsylvania. And I didn't know this until after we invited Dr. Fendrick to come. When he did his med school training at Harvard, he was buddies with Dean Lehrman. They were in the same class. I can't believe neither of them brought a picture, but hopefully we can get some good stories out of one of them before they leave. Dr. Fendrick's research focuses on the intersection of paying for healthcare and healthcare access and quality of healthcare. Lots of my favorite things. He's an elected member of the National Academy of Medicine. He has testified before Congress lots of times. He regularly interacts with top policymakers across the US. He's been involved in many things that we study in class and some of the most important health policy decisions in the last few years anyway. He wrote part of the Affordable Care Act. He was really involved in the price cap that's now been placed on insulin. He's done lots of work in the space of reducing cost of care for patients. To me, Dr. Fendrick is the epitome of a physician scientist because for lots of reasons, but one is because of his commitment to mentorship. He has so many of us that he is really gracious in his willingness to teach and train as the next generation of health services researchers. I'm so grateful for that. I also really appreciate that he's driven by the impact of his work and making a difference for patients like his and for patients all across the US. And he's more driven by that than necessarily by the impact factor of the papers he publishes and the number of papers he publishes. That said, he has more than 500 co-authored publications in the highest impact journals. So maybe we could all learn a little bit from that approach. I'll stop there and let Dr. Fendrick take it away.
The keyboard has disappeared. Good evening, everyone. It is an absolute honor and pleasure to be here. Dean Lehrman, thank you. Michelle, 3-hour drive and all the other types of things. It is fantastic to be here. When Michelle said University of Michigan for the first time, I did not hear one go blue. Is that the case? There's not one University of Michigan student in the class? Look, there's an OSU person. Good, good, good. Anyway, great pleasure to be here. I do give a lot of presentations, but don't travel very much. But I have a general rule in my live presentations is that the further you are from me, the more likely you are to get called on. So you in the back corner, try to stay off your Instagram for the next 40 minutes if that's possible. That'd be great. So I'm here to talk a little bit about a journey. And if any of you want to hear a little bit more detail about many of the things I'm going to touch on briefly, Jessica will send a link somehow to all of you that has this slide deck so you can put your computers away if you want to. There's a whole bunch of other resources that are very user-friendly for students like yourself to do a little bit of deeper dive into the things that we were doing. But most of my time is talking to fourth graders and policymakers. And I'm just thrilled to talk to students and people who are going to be clinicians and researchers, because that is generally not the realm of influence that I am these days. And listening to, I can't believe Michelle refers to herself as a mentee, but my mentor, one of his 10 commandments was be good to your students. You never know when you might need a job. So I look to that with Michelle and maybe all of you being my boss someday. That's certainly highly likelihood given the qualifications and the amazing characteristics of the some of you I've met during the reception. So here's the caveat, particularly for those of you who are pursuing this very kind of prestigious academic career like your dean and your colleagues have had. I'm not someone who's spent a lot of time actually writing grants and thinking about papers as a particular metric of an outcome. In fact, some of you might have heard the term publish or perish, right? I'm just looking for some nods, thank you. Well, this is the slide I've been using for every presentation for the last 20 years, which is I published and I still perished because I felt it very unsatisfying to work so hard on these research projects and write these papers and get them published and realize that very few people outside of your mother actually read them carefully, and that the impact, you never really know how to move them forward. And it's been particularly problematic for me because I really wanted to see ultimately what I wrote in my medical school personal statement, which is very similar to yours. A bird fell out of a tree, it broke its wing. I fixed the wing, it flew away. I want to help people. So we want to help. We want to help people. And I'm just going to take you through some things that are much more germane and relevant to PhDs and medical students, but also a little bit of the gist of how I try to explain what we're all trying to do as clinicians and researchers, got to make the world a better place for patients. So the first point is that for those of you who have time, particularly in your early stages of your medical school career, to follow what's going on in the healthcare space, particularly in the Commonwealth where you live, and the country and the federal policies that are being underway, it just seems to be that all healthcare discussions these days are about money, right? How much we're spending and how much we have to devote to Medicare and Medicaid and other types of things. And this is why it's so rewarding for me to be in front of you today to remind everyone is that there's never been a better time to be a patient or a clinician, right? When people talk about the good old days, it's absolutely not the case. Believe it or not, we're not that old. But Dean Lehrman and I, when we were in medical school, we didn't even know what hepatitis C was. It was called non-A, non-B hepatitis. Now we have the virus, its genome is understood, and we have drugs that cure it for life 98% of the time. So things continue to move forward at an incredibly rapid pace. And as someone who studies medical innovation, it's just even more exciting to think about what you're all working on and what colleagues like Dr. Greenberg and I could do to our patients in primary care that we couldn't imagine when we were medical students like yourself. So we like to think that we're going to follow the gist of our medical school personal statements, But if you look at the Commonwealth and more importantly, what's happening nationally, all people want to do is spend less on healthcare. And I wish I would have written in my personal statement, I did not go to medical school to learn how to make people money or to save people money. But if you go to medical meetings like I do, and you count how often they talk about money on one hand, you need about 10, and you hear people talk about actually why we're doing what we're doing to make people healthier, it's extraordinarily rare. And then when you're in the context of cutting people on the exchanges and cutting millions of people off of Medicaid and having people even with good insurance being less good, it's particularly problematic because those of us who want to make individuals and populations healthier, if you were to list whether you're a med student or a senior dean about the most important things you do in primary care internal medicines or obstetrics gynecology, all these things that we deem to be our highest quality metrics are substantially underutilized. Meaning I go to places and say we need to pay more for preventive care. We need to pay more for prenatal care and postnatal care. We need to pay more for chronic diseases and end of life care. And that is a real clash that hopefully by the time you're all finished with your training, a lot of these issues will be resolved. Because why I don't have jobs in other parts of the healthcare center outside of academia where people supposedly have a dog in the fight, either people who want to sell things to you like device manufacturers or drug companies, or cut the amount of spending, such as those who work for health plans and pharmacy benefit managers, is because what excites me about the field you're entering is what we're going to do is just remarkable. What's coming down the pike, cell and gene therapy and other scientists here in this room will tell you like what really excites them about what the potential implications of what they're doing might be coming down the line. I did not become a pediatrician, which I was so supposedly destined, because I spent a week taking care of sickle cell patients at Boston Children's. And to think that in my lifetime, there might be a lifetime cure for sickle cell anemia available to patients to which many of these people who would benefit might not get them because of cost is horrifying to me. And therefore, we just have to make some decisions about the current buzzword in Washington, where I was last week, about healthcare affordability. What does it mean and how should we be spending our money, given that not only can we not deliver the care that we deem to be high quality today, but thinking about the expensive but really exciting options that might be available to you when you're residents, fellows, and full-time clinicians. So again, because you're much more sophisticated than my typical audience, this first 5 minutes comes into an elevator, usually in the halls of Congress, and say, what the heck are you talking about, Mark? And I say, what I dream is what I call Star Wars science. And some of you might know Star Wars or not, but that's the future. Like many of the people in this administration think it's artificial intelligence that's going to make that happen, even though my kids call me artificially intelligent. But AI is going to be a big part of what you're all doing. But what I see and what challenges me in this motivation, which you'll hear about value-based insurance design, is Star Wars science is what we can do. But if you think about what we do, and I'm not sure what we do in Roanoke compared to Ann Arbor and Philadelphia and Boston, where I've been, what we do is what I call Flintstones delivery. Now, some of you might watch Nick at Night, but ask Dean Lehrman about Fred and Barney. He'll tell you about the Flintstones. But the idea of ultimately how we move from Flintstones delivery to Star Wars science, or from the Stone Age to the space age, is we have to change the conversation on healthcare in this country from how much we spend to how well we spend. And while people who are not trained as you all are, making my neck hurt, looking all the way up there, you guys, but you are the ones who ultimately determine what are those things that improve individual and population health. And I've been trying very hard to kind of move the money around, to understand that you've all seen this graph during that 3 hours Ed learned about on the US healthcare system, that given that we're coming out of the Olympics, we spend the gold medal amount by far on healthcare compared to other countries. But when it comes to the outcomes that we all care about, we don't even come close to the podium. It's kind of like the US cross-country skiers. We're always behind Norway and Czechoslovakia, all these other places. So it's incumbent upon us, the people who I think know what's best, along with our patients, to improve health, is to spend the money better. So one way, which is a lot of really smart people, which I am not, are thinking about how we pay clinicians and group practices in hospitals. But the focus of my career has actually been on the other side of the coin, not the suppliers or the providers like clinicians, but what about consumers and our patients? How do we convince them to do more of the things that we would beg them to do because we know the evidence and their preferences would suggest they're going to make them healthier? And I'm not sure how many of you, since most of your first year is spending time in the clinic and interacting with patients, but when I think about my fellow primary care providers, I wonder how often, whether it be here in the Commonwealth, in Michigan or elsewhere, where it is typical in a visit for a clinician to ask the patient, can you afford the things I'm recommending for you today? How many of you are watching The Pit? Wow. So you saw already, like, you can imagine whatever's following here, the issues on The Pit this season are informed by this talk, right? You saw, no spoilers here, you saw episode 1, the guy complaining about his deductible. You saw in episode 3, the guy with DKA who wanted to leave because he couldn't afford the hospitalization, right? I mean, the fact that the realities of patients' ability to pay, and they're thinking about come to see you and have you recommend what's best for them, is a real challenge. And I'm hopeful when you're Medicare eligible like me, up here, that those problems will be maybe not eliminated, but mitigated to some extent, that my patient doesn't have to have a bake sale to afford her insulin, right? I mean, this is a reality, I imagine, not only in Roanoke, Ann Arbor, but everywhere where you have been and where you're going. So if I were to ask you, how do we get patients to actually use more of the things that we really think are important? And if you were to know what the #1 small p policy intervention is, how we might encourage or discourage individual patients who have insurance to do the right thing, is we're asking them to pay more for everything. So even insured patients, even though you might think that insurance means coverage, when I was on Twitter 4 years ago, my third leading hashtag was insured but not covered, meaning you have a card that says you have a health plan, but maybe you don't do or don't know when you're in your mid-20s to realize that before your insurance kicks in, you have to pay thousands of dollars out of pocket that you don't have, which is a deductible for your plan. So I've been focusing very much on, as Michelle said, to try to remove barriers, financial for the most part, and now systemic, transportation, geography, other types of things, to make sure that when you see an individual and say, you would really benefit from service XYZ, that it's easy, not hard. And I know there's experts in this medical school who study burnout of physicians. It's largely because the things that we want to do as clinicians that we know our patients would benefit from is hard and harder to do. Prior authorizations, network, step therapy, other types of things that we hopefully can talk about when we meet tomorrow. So if you're on social media, since your computers are still open, this was my most tweetable soundbite and most quotable line. Americans do not care about healthcare costs. They care about what it costs them. So I have focused on out-of-pocket costs in my career, understanding that the grown-ups in the room, like all of you, need to understand what the government pays a manufacturer for a vial of insulin, or what a health plan pays your hospital across the street to deliver a baby or have bypass surgery. But my focus has largely been on what patients pay to get the care they need. And I don't even have a slide on this, and I'm looking for Lee, who knows, like the fact that we saw the Affordable Care Act pass in 2010, my shift came from uninsured to underinsured, and thought that was a path we'd be talking about for the remainders of our career. And I stand here in March 2026, understanding that I have to start thinking about uninsured patients by the millions again. So this is a back to the future thing I don't want to be. But I want you all to understand, despite that fabulous introduction by Dr. Rockwell, my work to try to lower the rate of people who report they can't afford healthcare, this line that you could see, I have not been winning. In fact, the number who report they can't afford healthcare because of cost is now 45%, some surveys up to 50%. I don't even put that up there because it makes me so sad. You need to also understand this vital side that I push for, asking people about willingness to pay. Healthcare costs remain among the #1 causes of personal debt. They are the leading cause of online fundraisers. And only in America, as you see from this piece from over a decade ago, people are the personal cause of bankruptcy of healthcare remains one of the leading things, suggesting that the system is not working the way we had hoped. So this is a new study just from last May, again, kind of giving you a little bit more detail about the problems of people not being able to afford the care they need, and understanding for even before people go to see their clinicians just to pay out of pocket for their insurance. You know, people have been talking about it costs your employer or the government or whoever is funding your health insurance, it could be Virginia Tech in some situations, has about the cost of a Toyota Corolla for every individual family every single year. And there is no end in sight in terms of how much money we ultimately want to pay for healthcare. So I want to ask, just for those of you, I don't know, you like most of you millennial, Gen Z, I don't even know you, but you young folks in the back, if I were to call on you, which I won't, including you in the farthest corner, to define what a deductible is, would you be able to do that? Oh, good. Sorry to hear that. I guess that's health system scientists or whatever you guys call it here at the fall. So 50% of, so my kids are millennials. So 50% of millennials don't know what a deductible is. But if you watch, all 4 of my kids have crashed at least one of my cars. So they damn well know what a deductible is, at least for auto insurance. So it's the same thing. It's how much you have to pay before this came in. And you see this slide, which is my oldest slide in the deck. I stopped adding new years. That when I got started looking at out-of-pocket costs in the last century, I like saying that because some of you weren't even born at that time. There were very, very few people with deductibles, and the deductible levels are really low. So it turns out that just about everyone now, except for super generous plans, have a deductible in their plan, and they've grown into very high levels. And understanding that the Federal Reserve says that 40% of Americans don't have $500 in the bank. And understanding that people who have insurance but high deductibles before it kicks in, they cannot afford to buy the services that they need on January 1st. And that while at one time Virginia Tech used to be in New Year's football bowl games like we are every year, but you were once. But most people like New Year's Day. Most people like the party on New Year's Eve. But as you get more accustomed to showing up in your clinic the first week of January, you will see a substantial proportion of your patients who are very sad the first week of January because the deductible they worked so hard to meet or worried about actually resets. And that same stress that occurred in the years past, and finally I met it, I could get coverage, starts over again. Which is why I typically will go on radio or TV every January 1st to remind not only patients but their clinicians that they have to pay attention to the out-of-pocket cost burden that we face, especially those who have potentially life-altering expensive drugs. So we'll talk about how we might want to remedy this. But every presentation I've given since I started thinking about out-of-pocket costs in the late 1990s reminds me of my inspiration for this line of research, which is my mom, who said, I can't believe you had to spend $1 million in grant funding to show that if you make people pay more for something, they'll buy less of it. This is because there were a lot of people making a lot of money out there suggesting that Americans can shop wisely and spend their own money on healthcare services. And one thing I'll tell all of you, young people, older people in this room, your mother is almost always right? So when we did studies to show that if you made people pay more to go to the doctor, they went less often. When we did studies to show that we made people pay more money to fill their prescriptions, they filled them less often. It was like the easiest path to tenure you could ever imagine. Like my colleague and I just like papers, now there's probably 200 papers in the literature in various things, including your field, that show that my mother was right. But imagine for someone like myself and many of you who are interested in underserved populations and issues of health equity, imagine what she said when I told her we had to do another $250,000 to show that poor people are impacted more by high prices than rich people, right? So that we made the very strong point that is incredibly obvious, at least to her, that cost sharing that's equal across all people and all services worsens disparities and health and worsens the health of underserved populations more than those who are affluent. So long before equity became the buzzword of the past administration, when we looked for a disparity reducing policy, this was one that was very clear in the fact that if we could reverse the trend on high cost sharing across the board, we hypothesized that patients who were most financially challenged would benefit the most. So following a line of this publishing and still perishing and understanding like how you actually make this decision to get out of the realm of the New England Journal and understand perhaps that maybe your message might be more impactful if you write in the Wall Street Journal. And in fact, there's now a multitude of stories that are now really hammering home the issue that out-of-pocket costs, at least by recent surveys, say is the #1 policy priority of the American public. And these are pieces that, Liam, so I get no credit at my university for writing in Fortune or the New York Times, but I will tell you that the implications of these and the impact of these are equal and sometimes greater than even those prestigious publications that Michelle spoke about. And if anyone wants to challenge this issue of the fact that people are really suffering and challenging the status quo of healthcare in the US, you could find a number of surveys documenting not that we care about the cost of healthcare, right? National spending on healthcare, 7% of people felt that was the priority, as opposed to almost half who care about out-of-pocket costs. So remember, Americans don't care about healthcare costs. You should all care about them and understand them, but understand that what really matters is what your patient pays on their way in or out of your visit, or when they go to the pharmacy to fill a prescription or to the lab to get a diagnostic test. So this is, this room is fabulously like a casino, so there's no clock in here. So, is that actually working? That's good. Okay, so I'm going to behave as if I'm fee for service because you guys all got really good food, but in fact I'm capitated, so I should keep. You don't know what those mean either. I'll explain them tomorrow, but you should know the difference between fee for service and capitation. But I'm going to spend a little more time because no one has fallen asleep yet. So yes, things are not great. Yes, Americans have to pay more for healthcare. Yes, they are going without, either uninsured or underinsured. And one of the things that kind of makes me different is that I decided around the year 2000 to not produce the coin of the realm and decide to try to fix this problem. How would I actually try to make it easier, not harder, for my patients to have access and to afford the services that I would beg them to do in my office? And what my colleague Michael Chernow, who is with me in Michigan now at Harvard and chair of the Medicare Payment Advisory Commission, came up with is that instead of the idea of blunt cost sharing, meaning your deductible applies to high value services and low value services, your co-payments for drugs in a particular tier of the formulary are the same for ones that'll keep you alive as opposed to ones that might treat your toenail fungus, right? So we decided that it would be a good idea. What if insurance actually set up a cost sharing system that made it easy to get the things that you and your clinician deem to be high value, and maybe a little harder for those things where the evidence is weak? And so we talked about this in the academic realm, and then we gave it a name. called value-based insurance design and came up with a snappy byline, which was more of the good stuff and less of the bad stuff. And basically, if it's an idea that I'm working on, it cannot be sophisticated. So what it basically said was, the things that you and your patient agree to be the most value should be low cost. As opposed to the current, including in the Commonwealth, cheap things are cheap and expensive things are expensive. So this is driven clinically, which is why it's so important to have all of you thinking, you're the ones who get to determine what the cost sharing is going to be, not the people on the business side of healthcare who typically are doing that. So we gave up our academic pursuits and started knocking on doors of large employers and health plans and said, do you think this idea of setting cost sharing based on clinical value, not price, is a good idea? And it turns out that a moderate sized company in Connecticut called Pitney Bowes, their CEO said, yeah, that's a good idea. We're going to start making our branded drugs for mental health, diabetes, hypertension, and cardiovascular disease. The branded drugs, we're going to put them on the generic tier. And it turns out, not the New England Journal of Medicine, but the Wall Street Journal of Medicine wrote a front page story on this crazy CEO who's going to say, I'm going to spend more on high value things and less on low value things. And it was because of that mention in the Wall Street Journal in 2001 that kicked the idea of value-based insurance design forward. We've now either impressed or guilted hundreds of public and private payers to put value-based insurance design in place. We have very rare bipartisan support. For any of you who are actually interested in state or federal policy, how unbelievably rare that is to get Republicans and Democrats to meet on this. And you can imagine what my mother said when we started publications showing that we made people less for something, they buy more of it, and they actually did better. Right. So this is, how many of you heard value-based insurance design before today? No? Really? Are you really? You the student, the blue shirt guy, you really heard of it before today? Yeah. Oh, you good, good. I'll get you a t-shirt. This is great. No, the point I'm trying to make is none of you, outside of maybe you said, oh yeah, you read it on Jessica's fabulous poster, but you've never heard of it before today, I don't think. And that's completely fine because you see that we've been working in the academic realm. I think what's really interesting and important to show you that this has got this incredibly rare situation in US healthcare. You know, Republicans and Democrats and management and labor and pharma and health plans, organizations that tend, Ohio State and Michigan, you know, organizations that don't like each other very much, that are all agreeing that out-of-pocket costs should not bankrupt you, especially for things like having a delivery of a baby or trauma surgery where you really have no choice regarding this forward. So even though you have not heard about value-based insurance design before today, I'd like to think that every single person in this room and just about every single person that you know has benefited in some way from the concept of value-based insurance design. And this is the conversations we turn now to the really kind of unusual and exciting aspects of VBID. So how many of you know, you don't know about VBID, how many know about Schoolhouse Rock? All right, so in 2006, I was taken to Washington to talk about this idea, and I sat on the steps of the Capitol for the first time since my 4th grade field trip, and I hummed Schoolhouse Rock, I'm just a bill, I'm only a bill, because I did not know jack about anything that went on in any type of policymaking. And it turns out that if you listen to people who know the process and are able to back up your ideas with evidence, to some people, few, and really compelling stories, many, you can move this idea forward. So we first got to the Congress, and this was a Republican-backed idea because it was largely, the VBID idea was run through large corporations like health plans and businesses. And then lo and behold, a colleague of mine at the Ann Arbor VA, her bridesmaid happened to be the health staffer of the junior senator from the state of Illinois in 2006. Anybody know who that is? So I had the great fortune to work with this guy, Barack Obama, to implement value-based insurance design into the Affordable Care Act. And those 3 paragraphs that we helped write are the paragraphs that make about 90 preventive services no cost to people with insurance, right? So if you have received, or your parents or your grandparents, free mental health screening, free cancer screening, cardiovascular screening, hepatitis C screening, weight loss counseling, the list goes on and on. It is because of our 3 paragraphs that we ended up into ACA. This is the U.S. Preventive Services Task Force A and B recommendations. These are the vaccines recommended by ACIP at the CDC, which those of you who are following what's happening in this administration is in real state of turmoil right now, as well as services for kids and moms supported by the Health Resources and Services Administration, or HRSA. So I was telling Michelle, like particularly most of you, at least those of you who are either basic or translational sciences, when you describe what you do, the depth of the intensity of what you do is just so impressive. Why I need to be around people who do that type of work, since I'm someone who has academic attention deficit disorder as a generalist. I need to be studying a whole bunch of things at the same time. So when people ask me what I do, and so are you ready in the back corner? This is what I'm going to call you. Ready? How much did you pay for your COVID shot when you got it during the pandemic? And this is where you say, thank you very much. So the point I ask you is, all of you who wanted to get tested or vaccinated, or the few of you who got treated for COVID, for the first 4 years paid nothing, right? Are there many other things that we really want that the government has given us for free? No. So I want you to think about how that actually happened. It actually happened because a crazy bald guy and a bunch of other people from Ann Arbor decided to convince Republicans and Democrats in the federal government that there are certain healthcare services that should be provided at no cost. And you probably all know that there's rhetoric and lack of partisanship, but the preventive services provision of the ACA has always pulled extraordinarily high, even among Republicans, till you tell them it's part of the ACA, then it goes down. But people like free stuff, especially like free stuff that you think is going to help your health moving forward. And the evidence of this is overwhelming. So we're talking at least 230 million Americans have benefited from the Affordable Care Act, particularly preventive services provision. And the people who have benefited most in the studies that we've done are the people who couldn't afford healthcare previously, suggesting that we've improved equity and reduced disparities. So I mentioned the COVID part, which was, how did this happen? The administration, the first Trump administration, needed a precedent in law to be able to say, we're going to make COVID shots, treatments, and tests free. And the number of people who took advantage of that is additional hundreds of millions in the US. And it comes as no surprise that when we look to see who are those folks who are actually eligible and using these services, it's consistently between 50 and 60% every year. Someone uses one of these things. They're very, very pleased to see that certain things like your mammogram or your Hep C test or whatever you're getting your screening doesn't cost you anything. No one seems to question or be concerned about paying nothing for services, nor do they really care about how it actually came. And for those in the preventive care space, it's just worth noting that the ACA preventive services provision was challenged in courts this past year. It went to the Supreme Court, and very fortunately, the Supreme Court upheld the ACA preventive mandate, which is why I think it's important for you all to understand that even though these things are free, whether it be contraception and some aspects of prenatal care, Lee, that you know very much about, this gives us a second chance to actually remind our colleagues and our patients that there are certain services that are clinically indicated for them that they actually don't have to pay for. And Dr. Rockwell and I just wrote an editorial on a piece just very illustrative of this situation, describing that large populations of people who are not very sophisticated in the healthcare system still don't know that lots of these preventive services that are indicated for them can be provided at no cost. So a little bit of action about an idea that ended up in the ACA Obamacare is what about what's happening in the first Trump administration and now what the current administration is thinking around value-based insurance design. I'm not going to go into these details, but I think it's really kind of illustrative and validating to see that our work that started in the George W. Bush administration really hit big in the Obama administration, had some action in the Trump administration, then the Biden administration, and still currently ongoing in the second administration, because I think people are really reacting to the fact that out-of-pocket costs are really problematic and are not, as difficult to fix as the overall cost of healthcare spending in the US. So a little bit on Medicare really quickly is that since I'm probably the only person in the room who's Medicare eligible, many people, particularly young clinicians, think that once you get to Medicare, you don't have to pay anything besides your premium. That's certainly not the case. And there are a number of studies showing how Medicare beneficiaries are just like those in commercial plans and Medicaid and uninsured who can't afford the care they need. So we've been doing a number of work in the Medicare space. And Michelle mentioned a few of these, but when the IRA, Inflation Reduction Act, was signed by President Biden, we were very pleased to see a number of policies that we had worked on, actually some of which during the first Trump administration were codified into law. So first is, and I'd love to hear from some of you who are actually taking care of patients, is the $2,000 out-of-pocket max annually for drugs for Medicare beneficiaries. And I would imagine that some of you already have seen patients who had spent several $1,000s previously out of pocket for their drugs, cancer drugs, autoimmune drugs, MS drugs, other types of things. And I'm just so happy to see these testimonials coming in before we could actually do formal research on this about patients being able to get the care they need and not use them or have to ration them in a way that are not clinically indicated. Second was a minor thing that we worked on, which was making vaccines covered under the Part D part of Medicare, no cost to patients, which was a glitch in the early ACA implementation. And Michelle had mentioned since the very beginning, my tagline is my patient should not have to have a bake sale to afford her insulin, because if she's a type 1 diabetic and doesn't have insulin, she will die, right? And still, although we have a $35 a month out-of-pocket max in Medicare, which may seem just like 5 coffees at the fancy coffee place in Roanoke, there's still a lot of people on a fixed income who find $35 a month a lot of money. And we still don't have an insulin copay cap for commercial insurance, despite our efforts since the early 2000s. And because we publish and still perish, it's been very important for us to basically show that this policy works, despite what my mother would say. So the insulin copay cap led to more people buying insulin, and making shingle shots free led to 50% more people getting shingle shots. So it just keeps me inspired and want to hear from all of you, like, what ultimately should we do next? And we keep quantifying the fact that people, millions of beneficiaries, are saving billions of dollars that have to be paid by someone else. But the patients are, for the most part, very happy when they have to pay less or more. So quickly turning to just what kept me up at night, and some of you know what a deductible was. So I felt once the law was passed, creating something called a Health Savings Account Qualified High Deductible Health Plan, the plan that the current president loves, right? So a health savings account, I'm not a finance guy, but is the only type of financial account in the United States that you could put money in tax-free, it grows tax-free, and you could take it out tax-free if you use it for the right thing. I love saying the triple tax advantage. I really have no idea what the hell it means, but I like saying it. I love HSAs. But high deductible health plans, you can imagine hearing when I say high deductibles, evil, right? They're blunt instruments and they stop people not only from buying the things they shouldn't buy, which is the motivation, but evidence is unbelievably clear that it stops people from buying the things that we would beg them to do. So it turns out, because I'm this unicorn free agent, I want to figure out how to fix this thing because I don't want to see deductibles or other barriers on the things that I am benchmarked on. The thing that my department chair says, your patient isn't getting enough A1C down, or their eye exam with diabetes, or using a beta blocker with heart failure, or getting your colon cancer screening done, or other types of things. And it turns out that by law in 2004, when these HSA high deductible health plans were created, because of the preventive services provision of the ACA, even if they don't want to, they have to cover those services mentioned earlier under the preventive services provision. But by law, even if you were a company who offered an HSA plan and wanted to cover any service to treat something that was already diagnosed, diabetes, mental health, autoimmune disease, whatever it is, you were not permitted to make that pre-deductible, meaning you could not cover it until the deductible was met, which I told you earlier, many people can't meet. And the deductibles are even growing faster now that even more people are at higher deductible plans, they can't meet it either. So you can imagine, for you in the back, that this time of year, maybe you and certainly your parents, if you have them or relatives or whatever, are working on their taxes and thinking about the IRS. And most Americans want to stay as far away from the Internal Revenue Service, like state policemen, as possible. And going back to the Flintstones metaphor, I am the guy pounding on the door of the Treasury Department, Wilma, let me in, to argue that it should be optional for health plans if they want to cover certain services before the patient meets the deductible. That should be allowed, largely because it helps patients, which motivates us, and it wouldn't cost the government a lot of money. It might actually save the government money for very technical reasons if we're that. And lo and behold, during the first Trump administration, they announced an executive order, 2019-45, that actually allowed these high deductible health plans to cover certain services on a pre-deductible basis. And I could even ask a first-year med student, let alone a third or fourth-year med student, what would be some of the services you want to have on that list? We provided the Trump administration this list of 14 services, just the start of these things that you would consider to be no-brainer, high-value services, aren't very expensive. And it turns out that these are the services that were codified into the executive order. And it shouldn't surprise you or my mother that when we studied the impact of expanding pre-deductible coverage, people use those services more often, right? So this has been very rewarding for us, but 14 services, nowhere near enough. I think each of you might have a list of 3 or 4 things that you'd like to see waived from deductibles. Please send them to me. This is the important part of this presentation, is this is an ongoing dialogue, like daily. It's not like these stories are ending. As you'll see, we're always continuing to try to make these high value services, of which evidence and preferences are clear, accessible and affordable. So here's a current version of a bill that we keep resubmitting on the floor to allow more and more pre-deductible coverage. And this has been the last Congress that a Republican-led bill of expanding the pre-deductible coverage thing was passed, and we're still hoping to move this forward. Really quickly, as we wind down here, I will tell you that our efforts to continue to introduce and have policies become regulations in the US that help patients continue. I think we all know that there are real issues that we may not feel positive about the One Big Beautiful Bill Act, but we worked, under the scenes of these larger issues of Medicaid cuts and changes to the exchanges to allow more things like telehealth to be covered on a pre-deductible basis in high deductible health plans. We have issues of direct primary care that these contributions had previously not been allowed pre-deductible, now they are. And the fact that there is going to be expanded role for value-based insurance design to make plans that are not very good, bronze plans and catastrophic plans, at least a little better the fact that these $15,000 deductibles in the bronze plans and maybe $30,000 deductibles in the catastrophic plans to allow certain services to be covered before the deductible is met. So here's where the great Dr. Rockwell comes in. So some of you will be thinking, all this Fendrick guy wants to do is spend more money on healthcare. My first slide was like, we can't afford the stuff we have now. People want to cut. How do we cut these things? And my whole career has been about more of the good stuff and less of the bad stuff. But luckily for me, until 2010, no one actually pinned me down to say, you have to be a low value care guy, not just a high value care guy. And since I want to be known as the guy who made things better, I have to find people to be bad and talk about the stuff we shouldn't buy. So that's where Michelle comes in. And it turns out that the options, just coming from Washington last week, if I were to ask you, how do we spend more on GLP-1s? How do we spend more on prenatal care diagnostics? How do we spend more on mental health services? All these things that are underused. The answer is basically for the first 15 years of Mike and my doing this, with either raise premiums on everybody, which is a political non-starter, or you just continue to raise co-payments and deductibles, which is a tax on the people that come to see us. One's bad, the second one's worse. And in 2010, I was forced by my advisory board to become a low value care guy. Because remember, that first bullet of my first slide is there's more than enough money in the system, right? It's just we're spending it on the wrong things, on the wrong people, in the wrong places at the wrong time. And you are the folks who actually could help do a better job. I don't want it to be only a bot to say, you should get this service in this place at this time by that provider. So we've been embarking now since 2010 on an agenda to identify, measure, and hopefully reduce low value care and no value care in the hopes that we could spend more on the stuff that's not covered generously now, either to lower premiums or deductibles in a macro way, or to add more things to the pre-deductible list, which cost money. GLP-1s is a currently hot topic for me. There's already some statute that we helped write that says that the Secretary of Health and Human Services may not cover the D-rated services as designated by the U.S. Preventive Services Task Force. That sadly we all do. I'm looking at my colleagues here, not infrequently in this situation. So maybe if we didn't get paid for those things, we might do less. And on bequest of the administration, we just published a paper in JAMA last summer, basically saying if we started attacking the low-lying fruit, or what I call the fruit below the ground, the things that our own professional societies say in their choosing wisely lists we should not do, we could save $3.6 billion a year. So the momentum has kind of started. What about this low value care agenda, right? And here is so lucky for me to have Dr. Rockwell helping me out on a number of studies here about looking at low value care spending in the Commonwealth, as well as some papers that is going to get a lot more attention on the use of services that are not evidence-based and not included in guidelines, but actually not only occur during the COVID pandemic, but are being promoted, sadly, by non-clinician influencers who just think that they could say something and people should do it. So the idea that, lucky for Michelle and I, that there's billions of dollars being spent on things that we wouldn't buy if they were free, but how we ultimately convince our colleagues and our patients who come in demanding this stuff, even though in many situations we know they're not clinically valuable. And we made some progress. The first CMS model looking at wasteful or inappropriate care is being launched this year. And we're just very, very interested to see if ultimately we could pull some levers to reduce the utilization of things like skin substitutes, nerve stimulators, and knee arthroscopy. I mean, there are 5 randomized trials that show that we shouldn't be doing scopes on the knee. I don't want to know if part of that fabulous new hospital you're building is doing a lot of knee scopes, but I would imagine there is this big difference between the idea of revenue streams and satisfaction for clinicians and patients and following evidence. It's certainly not easy, very challenging. Last part. So putting it all together. I want more of the good stuff. I want less of the bad stuff. And this is ultimately going to be really hard unless we get stakeholders behind the idea that we can't continue to just cut things in a way that lead to really bad outcomes, like leaving millions of people without insurance. And the last Trump administration asked our team to create a value-based insurance design model for the exchanges to see if it could replace actually what's going on now. And you heard about the subsidy debate and other types of things. And Mike Chernew called this VBID X, VBID for the exchanges. And it's a very simple thing that basically just robs low value care Peter, the money we're spending in red, and taking those savings and spending it more on high value care Paul, right? So this is just moving the money around. No, there's not a nickel more spent. And we wrote about VBID X. It ended up in the Federal Register with high endorsement for the first Trump administration, some examples of things that we want to see lower cost and higher cost on the right. But this is the dialogue, more of the good stuff and less of the bad stuff. And I was extraordinarily pleased that Michelle led, which is now kind of the best example of a micro level VBID X, which is taking the current people who screen positive on cervical cancer initial testing, first test free, and not until next year, the follow-up colposcopy and other types of tests you need are now not fully covered and certainly not deductible exempt. And I was trying to figure out a way to move the money around. And then Michelle had this ability and insight on the fact that over screening for cervical cancer is one of the more prevalent low value services. And what she showed in this paper, in fact, is that if we had the courage and the ability to stop spending the money on things that we shouldn't be buying, we could almost entirely cover the entire cervical cancer screening process. And while some of you may not even be interested or care about cervical cancer screening, what was so important about this paper that Michelle led was that it actually showed individuals that it can be done. The idea of doing fewer EKGs for patients that are low risk, undergoing low risk surgery, to allow resources to be available to people to undergo higher cost, more technical cardiovascular procedures. Same for radiology, where we want fewer people to undergo high cost imaging, CTs and MRIs for low back pain, but we want them to invest more money in diagnostic radiology and low dose CT scans and follow-ups for people for lung cancer. So I think the moving the money around is something that's been a little bit more palatable to our clinician colleagues who are worried that all I'm trying to do is take their money away from high revenue producing services that don't really produce much clinical value. So I think I am 2 minutes over. I think this is my last slide. And I want to just tell you all that I know some of you have to stay, leave. So that's why the students can't leave. So I love the fact that everybody stayed and stayed awake the whole time. Thank you all for coming. I want you to realize that Michelle could vouch that this, and certainly Dr. Greenberg, I mean, you guys know what it is to sound like a broken record. Ask Dean Lehrman what that means. I've been talking about the same story now for a very, very long time. We need to spend our money better. And I was telling Michelle in the car, my tagline for 2026, this is the first time I've said in a presentation, is that money should follow health, as opposed to what's currently happening where health is following money. So if we basically said, we're just going to continue to devote $5 trillion, which I have nothing about, as long as every one of those dollars goes to something that we all agree is evidence-based and help a patient, so be it. But while we're spending 20% or $1 trillion on things that don't help patients, we're particularly problematic. And so how do we do that? One is to keep an eye on the preventive care mandate. And I hope some of you are actually following, at least peripherally, what's happening with Secretary Kennedy and what's going on there regarding preventive services. We need to continue to work hard on reducing barriers to high value services. And it's not just money anymore. We've had some successes on out-of-pocket costs, but there's issues of prior authorization and utilization management and other types of things that your colleagues here who practice full-time are dealing with on a daily basis that's only getting worse. We need to have the courage as clinician leaders to stop doing the things that we do because we can, but we know in our hearts that they're very, very unlikely to help patients. And most importantly, I think, is that it's putting patients first and not the issues of money and revenues first. And that's why you all, as clinicians and future clinicians and researchers, it's not just the idea of blunt instruments. It's not the idea of just making cuts and kicking people off insurance rolls. It's they should be clinically motivated, these decisions. And the only people who can make clinically motivated decisions are clinicians, right? My favorite high value services: colorectal cancer screening, coronary stents, back surgery. My 3 favorite low value services: colorectal cancer screening, coronary stents, back surgery. The folks in DC believe an AI bot will be able to figure that out. I believe that we need to be intimately involved in leading that moving forward. Because as I leave you, and thank you again, I always show the largest outdoor football stadium in the country. But more importantly, my favorite political quote, most of you students don't know who this is, but this is really how I feel about the VBIT story, beginning and ending, which is, if we don't succeed, then we will fail. So with that, I'll leave it up to you to decide if there's time for questions. I'm probably over. I know some of you have to go, but thanks again for the invite, and really appreciate your time.
Thank you so much, Dr. Fendrick. If you have to leave, you guys can go. But other than that, any questions?
There we go. Would you mind introducing yourself, please?
Sure. I'm Daniel Kotopetsky-Cox. I'm a first-year med student here. I'm presumably spending more on preventive services should reduce costs of complications and hospitalizations down the line, and ultimately keep patients healthier. Do you have data that shows that?
Are you a plant, or are you punking me? So you guys should all leave. So Daniel, you said your name was? So the most challenging question for those of you who care about the bird and helping the bird fly away, as opposed to people who have to, like Dean Lehrman, who understand that money makes the world go round. The biggest challenge of my entire career, and Dr. Rockwell sadly had here this for about 75 miles of our many, many 100-mile trip from Charlotte, is that most people, and if I were to ask you, since you're so kind to stay, how many of you actually believe that good preventive care saves money? So even Lee, so I went to University of Pennsylvania, founded by Benjamin Franklin, who's the guy who said an ounce of prevention is worth a pound of cure. That is the case when it comes to clinical outcomes, which motivates me. The problem, Daniel, is that the things that you will learn to, no matter what field you pursue, to be most valuable from a clinical perspective are cost effective, term you may not have heard before, as opposed to cost saving. Cost effective means high value. You have to pay a certain amount to achieve that outcome, to prevent a heart attack, to detect a cancer early, to treat mental health. All of the services, not just preventive services, but all the chronic disease services, all the things that we've studied, for the most part, that we recommend as high value are cost effective. Meaning, the great quote from Michael Chernin, if you buy more things that don't save money, you will not save money. Okay? So I am, this forehead and this, I've been banging my head against the wall, particularly in DC, for 30 years. People do not want to believe that the things that we are all recommending as clinician quality metric leaders are not cost saving. You might have heard a guy by the name of Woody Allen. You know who that is? Woody Allen said, the best way to reduce expenditures is death. It was true in the 70s when he said it. It's true now. So why we are focusing on low value care, led by Dr. Rockwell nationally, is because most of these things, because they're cost effective and you live longer, and by living longer, you have to spend more on healthcare, we're in this serious conundrum. So thank you for raising my blood pressure, and thank you. I was getting on it pretty easy, but that's a very important point to make, and that affordability, which is the buzzword in DC, if it actually means cost savings, spending less than we're spending now with what we have coming down the pike, is going to cause a great problem for your entire generation, because I just don't see that as feasible. Oh, we got someone in the bleachers, cheap seats too. This is great.
Hi, my name is Cleo. I'm a second year TBMH student. My question is, you were talking about like the high value care will have to be decided on between the providers and their patients, but how will that be affected when a lot of these corporations are like national level, but it kind of seems like a lot of times different health problems are more prevalent in different areas of the country, including like such socioeconomic status.
Right. Question.
Yeah, how would that work? Like, how would the coverage change based on geographic location?
So, I'm just presuming you're a bit younger than I am. I trademark a term called personalized benefit design in 2000 which made no sense and made me no money. But in the field of artificial intelligence and what these people that are your age who are running the country are claiming we can do, is that imagine a situation and you're seeing a patient or you are a patient, and on the information, this incredible amount of information is available, it basically says what the clinical benefit is or not for a particular service. And at that moment, it is determined whether your insurance plan covers it or not. That's not what the patient out-of-pocket cost. That's just the first thing, which the wiser model that I mentioned is already doing 2026, 2027. But even better for me, that same artificial intelligence actually informs me what your cost sharing should be. So if you're 45-year-old, like Dr. Greenberg, you get your colon cancer screening for free. But if you're over 75, like I will be soon, you should not get colon cancer screening unless you have some estimate of living another 20 years. And this is, my artificially intelligent brain that could do that. But imagine all the information that we'll have about your history, your family history, the geography in which you're in. The fact that now experts, scientists like yourself say if you live in an area with high amounts of air pollution, your risk of certain conditions are higher than those who live in low. So this gives me a headache, but should excite all of you about what the potential is to actually move down the pike from this, what I call blunt implementation, to something that's really personalized and driven by evidence. So I trusted you're going to take care of that. Fix it for me. I see you. Last question.
Hi, my name is Sudave. I'm a first year med student. Thank you again for your talk. I was just curious about your points regarding low value care. How much of that do you think could be attributed to kind of the fear of litigation, right? Or if I show this to an attending or an institution and say, hey, well, here's some ways we could do low value care, and they say, well, I don't want to get sued, so we're going to order the EKG anyways.
See you tomorrow, Lee. But he will remember when we were med students, I spent a lot of time in the corner basically saying to attendings, why would you do that? Why are you ordering labs every single day on a hospitalized patient? Why are you getting an x-ray every day? All these types of things that just the answer was because we can. So I'm going to return your pickleball, sir, to ask you, to tell you and then ask you something. I believe that CYA, fear of litigation, is a minor contributor to low value care. It is real, but it is low. What do you think, and you could call a friend, what do you think the leading reason is? What do you think if I were to go to his colleagues and say, why the heck are you ordering a urinalysis on every patient who comes into the, things that primary care doctors do routinely, order vitamin D tests on people, like they're not, so why? So you go first. They're not going to answer. What do you think?
Derek, what do you think?
So Derek's thinking it's because they're greedy, right? Derek, it's a fee for service, which we're not getting into. We could talk tomorrow to some of you. The fact that still in this Commonwealth, most clinicians are paid based on what they do, regardless of its clinical value, right? Look at me, Derek. Never ask a barber if you need a haircut. right? I could find a barber to cut my hair every day because she is fee for service, right? So the other side of my first slide, we need to figure out payment reform for the two of you. But secondarily, I don't actually think, talking now to hundreds, if not thousands of doctors about low value care, that it's actually greed. And this is why I'm just looking for nods or not, and you guys could respond. We were trained in an era and our patients were led to believe that more is always better. Oh, I could order this x-ray, but I'm not really sure you need it. I could order this diagnostic test. I could refer you to my friend to do an upper endoscopy for your simple heartburn. I believe that, and this is a great, both of you, I remember Derek, I don't remember your name. But what's, you all need to think from today moving on. We have to change the culture of more is better. It is untenable. It is, more importantly, unsafe, and it does not lead to better outcomes. And the more you're able to think through and not having some YouTube influencer tell you what skin products you should be using for your acne, you know what the evidence should be in that particular situation. And I think ultimately that, sure, we've studied a lot about concerns of litigation. It turns out in states with litigation protection as opposed to not, the services that we focused on are ordered just as often, suggesting that, sure, it might be in the back of my mind, but even if I didn't worry about litigation, I would still order that ankle x-ray, even though the auto ankle rules tell me I shouldn't. So I'm seeing a lot of really wonderful nods you can't see from your colleagues in the front. But so enjoy the rest of your evening. Don't fill out an evaluation, I don't think, because there is one. And thank you all again for your attention and stay.